eczema is 14 to 50%, and carbapenem is almost 70% resistance in E. coli and Klebsiella. So among these search study, we go for the 6 mainly clinical trials, which are significantly landmark in the sepsis, neonatal sepsis studies. First one is the Danish study, which is published in the 2014. So this study concluded that incidence of total sepsis was 14.3% and culture positive sepsis was 6.2%. And they are showing that 64% isolates were gram negative, including Acinetobacter, Klebsiella, and E. coli. And high rates of multidrug resistance were observed in Acinetobacter species, Klebsiella species, and E. coli isolates. Higher in the culture positive sepsis, that is by multidrug resistance organism, which is 15.7%. After that, in 2018, there was another study was published, which was Anisha study, which showing that mean incidence of bacterial infection was 13.2 per 1,000 live birth, and
so recording has started now.
Can I start?
Okay, so before we start,
Okay.
Good evening, friends. We are from Pramukhswami Medical College, Bhaikaka University, Karamsad, Gujarat. So today we have a journal club presentation by Dr. Rohan Modi. He is a second year DM resident, and myself, Dr. Dipen Patel, professor and head of the Department of Neonatology. I welcome you all, and I request Dr. Rohan Modi to start the journal club. Yeah, Dr. Rohan.
Yes, sir. Thank you, sir. So today my topic is General Club in IN Knowledge Series. So we selected article. The article name is a multi-drug resistant sepsis in special newborn care unit in 5 district hospital in India, a prospective cohort study, which was said Global Health in 2025 and published on the 26th February 2025. So this is a prospective observational cohort study. Background for this study, because we selected a study, is nearly 1/3 of newborn deaths are caused by systemic infection, also referred to as neonatal sepsis. Up to 30% of deaths from neonatal sepsis have been attributed to AMR. Recent report indicate increasing rates of resistance to first-line and alternative therapies in some sub-Saharan African countries. So this figure is showing that the main reason for neonatal death are preterm birth complication, which is for 25.5%, and the third one is main responsible is sepsis and meningitis, which is 7.9. In also preterm birth complication, there is sepsis is also there. So most of the cause of death in the neonatal death are the sepsis and the preterm birth. And this infographic is showing that almost pneumonia and sepsis is a leading cause of death and disability in children under the 5. And 40% of the bacterial infection in newborn are resistant to existing antibiotic. In 2017, only 2 out of 37 antibiotics being developed in adult and were being studied in children by FDA. So almost 214,000 newborn die each year from drug-resistant sepsis. And here is in the second infographic. This is the status of the current status of the SNCU in the India. There were more than 1 million newborn are admitted in the SNCU. The tertiary care hospitals are very less as compared to SNCU. SNCU is the backbone of the peripheral and district hospitals, district areas. So there are almost 1,000 SNCU located in district hospital across the India, and SNCU is a primary care for any sick newborn. Among SNCU, there will be sepsis up to 1/4 of the neonate, especially those refer from other health facility for home. And in that, approximately 40% newborn admitted to SNCU receive antibiotics during their stay. So if 10 newborns are get admitted per day, so among them at least 4 to 5 newborns are receiving antibiotics per day. So from background, we can see that antimicrobials, the development and the rise of antibiotic resistance. Initially, development of the antibiotics were significantly higher, but in last few years, there were resistance developed so rapidly. As per the ICMR, which provided report of 2023 susceptibility report for some most common organisms like E. coli, Klebsiella, Acinetobacter, Pseudomonas. E. coli is only sensitive to 42% of the 42% cases are only sensitive to piptas. Amikacin sensitivity is 68% and Virobanan 66%. So this is showing that almost all antibiotics are now getting resistance. Even meropenem in Klebsiella is only 38% sensitive. So WHO in 2023 given antimicrobial resistance is one of the top global public health concern in the top 10. So this data we can show, we can see that in initial years from 1996 to 1988 and 2000, there were less drugs which were resistant. Meropenem was found FDA approved by in 1996, but resistance was reported in the 2001. On the same side, ceftazidime avibactam was approved by FDA on the 2015, and the first case resistance reported in the 2015 only. Main reason for the growing threat of AMR in the India, there were a lot of main issues like antimicrobial drugs are not used properly, unrestricted cells and suboptimal use of antimicrobials, excessive use of antimicrobials. Prescriber are not trained appropriately when prescriber are unsure of the cause of patient symptom. The correct antimicrobial and dosage is not available, and another antimicrobial is prescribed instead. So because of all this reason, WHO and UNICEF developed two standard indicator for preventing such infection control, preventing this antimicrobial resistance. They indicated there are mainly two goals in sustainable development goal. One is the percentage of bloodstream infection due to selected antimicrobial resistance organism, and a proportion of health facilities that have a core set of relevant essential medicine available and affordable on a sustainable basis. So before this study, in this article, they mentioned that the screen and total citation are 3,866. Among that, they selected 24 studies for the burden of needle sepsis in secondary care hospital. For that, the mainly key findings of their initial strategy was median neonate with culture positive sepsis was 40. Incidence of culture positive sepsis is 3 to 45 per 1,000 live birth, and 1.1% to 10.5% incidence in the all over the admissions. And among them, early onset sepsis are 54% and 62% of the cases.
Rohan,
Yes, sir.
yeah, you are telling about median neonates with culture positive sepsis means 40, right? What do you mean by
Yes,
this?
sir. Yes, sir.
Explain this 40 median neonates with culture positive sepsis. What does it mean?
Yes, sir. Sorry, sir.
Median neonates with culture positive
Hello.
sepsis. Ah, are
Uh,
you able to hear?
Sir, your voice is broken. Hello.
Yeah, the first point.
Hello.
Yeah, can you listen
Hello.
now? No worries, go
Sir,
ahead.
your voice is broken.
No worries, go ahead.
Hello. Hello.
No worries, continue, Rohan.
Sir, your voice is not coming. Hello. Antibiotic use and curve resistance, and WHO expanded and updated AWARE group in 2000, which can be used as a first line for neonatal sepsis. This is a second group watch. It can be used as second line, but reserve group is reserved for the multi-drug resistance. But after this, in 2021, there was another study was published on a global level, Bernard study, which is showing that 70.42% neonates were given antibiotics among admitted neonate in the tertiary care hospital. And among them, reported mortality was lower for neonate treated with ceftazidime amikacin rather than ampicillin and gentamicin, which was given as a first line by WHO. And 97.2% gram-negative isolates were resistant to ampicillin, and 70.3% were resistant to gentamicin. So basically, this raised question about the empirical use of combined MP-Genta for neonatal sepsis in lower middle income countries. After that, in 2023, there was again one study published, which was NEO-OPS, which is showing that antibiotic regimen used in the neonatal sepsis commonly diverges from WHO guideline, and trial of novel empiric regimen are urgently needed in the context of increasing antimicrobial resistance. And after that, currently another trial is going on, NEOSEP1, which is running from August 2022 to December 2028 to decide the newer antibiotic combination and Their aim is determine the ranking of existing available combinations to treat newborn babies who are in hospital with severe sepsis. So, what is the need for this study in 2025? Healthcare providers in most SNCU initiate antibiotic in neonates suspected of sepsis without testing blood culture because of the less reliability, less availability of bacterial system, and there is no that much sensitivity and specificity of the bacterial system in the SNCU. Without information on the local flora and the antibiogram, the choice of antibiotic remains empirical and broad spectrum, potentially fueling the AMR. Additionally, given the absence of facility for performing blood culture in most district hospitals, there are no reliable data on burden of culture positive sepsis, pathogen profile, and AMR pattern in the SNCU. So, the aim of this study was to fill this gap by examining the clinical and microbiological profile of sepsis in district hospital. This study mainly conducted in the 5 SNCU, Government Hospital Kadlor, District Hospital, Regional Hospital Una, Civil Hospital Sivasagar, and Government Nahata Hospital Balotra, which are linked with the main tertiary care institute like JIPMER, All India Institute of Medical Science Raipur, Government Medical College Chandigarh, and Assam Medical College, and AIMS Jodhpur. So this was their methodology. They enrolled the neonate from the inborn and outborn, and after admitting the neonate, they identify the sepsis by clinical team with the prefix criteria by clinical sepsis. And after that, they send the diagnostic test like sepsis, CRP, and blood culture. And empirical antibiotics started with the first line, whichever is their unit policy. If baby deteriorated, then they send the repeat blood culture and upgrade the antibiotic as per the unit protocol. And meanwhile, they trace the blood culture sensitivity. These blood culture were sending to the tertiary care hospital, which are linked to the SNCU. And they decide the outcome parameters. And according to outcome parameters and the culture sensitivity report, they classify the newborn into 4 categories. So, what are their outcome parameters? The primary outcome was the incidence of culture positive sepsis. Secondary outcome were incidence of early onset and late onset sepsis. All cause mortality. All cause mortality means death within 28 days of life, regardless of the underlying cause of death. Case fatality rate, death attributable to the sepsis within 28 days of life or 21 days of sepsis suspicion, whichever was earlier. And the last one was the profile of isolated pathogen and antimicrobial resistance pattern. So among 6,960 admissions, they enrolled 6,612 admission after excluding neonate. Among that, 3,255 suspected of never suspected of having sepsis. So final inclusion of the sample size is 3,357. Among them, 1,739 were inborn and 1,618 were outborn. So, after they trace the blood culture sensitivity report, among them 2076 are culture negative sepsis, 213 are culture positive sepsis, and 1068 are suspected sepsis, but not labeled as culture positive or culture negative sepsis. So these are some definitions they used for the culture positive sepsis, culture negative sepsis, and suspected but not labeled as either culture positive or culture negative sepsis. First one is neonate with suspected sepsis and isolation of or recognized pathogen. From blood, CSF, or other body fluid. If coagulous negative staphylococcus, it should be cultured from one or more blood sample drawn on separate occasion. On the organism cultured from blood is not related to an infection at another site. Same applied to the culture negative sepsis. Neonate with suspected sepsis and negative blood culture or blood culture deemed to have grown a commonasal and clinical course consistent with sepsis, or the neonate received at least 5 days of antibiotic. They gave the third category, suspected but not labeled as either culture positive or culture negative sepsis. Neonate with suspected sepsis and negative blood culture and clinical course not consistent with sepsis or any other attributable cause identified by the sign. And the neonate received antibiotic for less than 5 days. And the last category they gave as a new episode of sepsis, which is when the neonate becomes symptomatic after 48 hours of stopping appropriate antibiotic therapy. So the statistical analysis applied for this study are descriptive statistics and they calculate the incidence of sepsis. They gave the case fatality rate by dividing deaths attributed to sepsis by the number of neonates with sepsis. They gave Cox proportional hazard model and the Kaplan-Meier survival curve, which is showing that date outcome from the date. So these are the result. First one is the maternal variable. So among maternal variable, we can see that antenatal corticosteroid in 635 anticorticosteroid 35 week gestation is given in the 31.4% in the inborn and 6.1% in the outborn. Maternal antibiotics within 7 days before delivery, 49.4 inborn percentage patient received maternal antibiotics and 16.8% patient received antibiotics in the mother in outborn patient. So, what is the importance of antenatal corticosteroid in 35 weeks, less than 35 weeks of gestation? So, we can see that there was a one trial, one Cochrane review, which is published in 2024, which is showing that antenatal corticosteroid for accelerating fetal lung maturation for women at risk for preterm birth. There was a Cochrane review, which is showing that systemic infection in the first 48 hours of life are significantly decreased on those patients which received antenatal corticosteroid. And the another thing is why we are highlighted the point maternal antibiotics within 7 days before delivery, because there is an interesting article which is published in the 2022, which is showing that if we give antibiotics, if we give to the antibiotics in the baseline community, which is showing that after given antibiotic, these yellow organisms are cleared by this antibiotic, but this red and green are which is not sensitive to these antibiotics are still there. And there are two ways to proliferate these things. One is those organisms which contain that plasmid, which is resistance to these antibiotics, are growing by significantly, and they also transmit their gene of resistance in the other organism which are actually not sensitive or resistant to that antibiotic. So these misuse of antibiotics causing the organism overgrowth of resistance strain. So this is the neonatal variables. Among them, there are 3,972 in the inborn and 2,640 in the outborn. So gestation wise, mean gestation age is 37.5 and 36.6 in the outborn. And they didn't give the how many newborns are the low birth weight in the inborn and the outborn. Mainly in this neonatal variable, there were kangaroo mother care given in the 16.8% in the inborn and 21.8% in the outborn. And bed sharing is the main concern in the SNCU, which is 13.4% in the inborn and 25.8% in the outborn.
What do you mean by bed sharing?
Sir, means there are 2 or 3 newborn in the one trolley. This is the common issue in the SNCU.
Okay.
Because as per the SNCU formative structure, they recommend that if some amount of deliveries were happened in the month, then they gave the only 10 to 12 beds in the SNCU. But because of there was a target that this much admission needs to be showing, so they are keeping 2 or 3 babies in the SNCU in single bed.
Okay.
So one interesting study published in the BMJ Global Health, that kangaroo mother care for preterm or low birth weight infant, a systemic review and meta-analysis, which was showing that severe infection or sepsis until at least follow-up is significantly reduced in if we are giving KMC to the newborns which are less than 2.5 kg, as compared to conventional neonatal care, which is showing 215 per thousand live birth. So this is the main result of this study. Overall incidence of sepsis is 3.2%, 213 among 6612, and case fatality rate was 78 among 213 inborn overall. So, place of the birth, inborn and outborn, 81 newborn having sepsis among the inborn neonate and the 132 in the outborn neonate. And early onset sepsis mainly seen in the 124 in the inborn neonate, and a late onset sepsis in the same and the 89 neonate. So the among common isolates, there were the most commonly three are Klebsiella, E. coli, and Enterobacter. All are the gram-negative organisms. 22.9% cases showing Klebsiella, 14.8% showing E. coli, and 11.7 is showing Enterobacter. But again, 13.9 are showing coagulase negative staphylococci. So this is the antimicrobial resistant pattern of common pathogen. Klebsiella, E. coli, Enterobacter, and Acinetobacter. Most of the organism are multi-drug resistance. Klebsiella is 84.3%. E. coli are 84.8%. Enterobacter are 88.5%. And Acinetobacter are 75.0%. All four organisms are this much multi-drug resistance. Single antibiotic also resistance in all these gram-negative bacilli. So this is Kaplan-Meier curve for all-cause mortality by sepsis status. Y-axis is showing survival probability. The highest probability is 1 and lowest probability is 0. Among that, highest probability is showing that sepsis, this green line is sepsis not suspected. Those newborn babies which are not actually septic are showing highest probable survival. And culture positive sepsis had the lowest graph. This is real graph, which is showing that lowest probability of survival in the culture positive sepsis. This is the cause of death as per the different cause of death. Among them, sepsis is mostly seen in the 27.6 percentage, and 21.2% in the inborn and 31% in the outborn. So key finding of these studies are high but varying incidence of culture positive sepsis at the study sites, predominance of gram-negative bacilli among neonate with culture positive sepsis, a high case fatality rate particularly among neonate with sepsis caused by gram-negative bacilli, an alarming degree of antimicrobial resistance to even antibiotics such as meropenem, largely unreported from district level facilities. Key policy and research implication from this study. There is an urgent need to strengthen infection prevention and control practices in the district hospital. Policymaker must consider establishing blood culture facility in district hospital. Healthcare provider must develop context-specific protocol for identifying and managing sepsis and implement an antimicrobial stewardship model that is feasible, effective, and sustainable in district hospitals. So strength and limitation of these studies are key strength is establishment of a district hospital tertiary site diet. This was the first study which having this characteristic that SNCU are linked with the tertiary hospital and they support them with the they mentoring the site and provided access to the microbiology laboratory and support to district hospital investigators in study implementation, because most of the SNCU have lacked the facility of the blood culture. And other several limitations are it might have overestimated the incidence of sepsis by coagulase negative staphylococci, the diagnosis of which was not based on two simultaneous blood culture. But as mentoring by tertiary care hospital, they scrutinize the result. They follow by the team expert at the nodal center, review the history and clinical course of all neonate with positive blood culture, including cons, and assign the label of culture positive sepsis. So after looking the history, they gave the result that yes, this can be cons, which is pathologic. And another limitation is the study sites were from different geographical area and had varied patient profile infrastructure and practices, which resulted in the considerable heterogeneity in the sepsis burden and the case fatality rate. The site with the highest burden had more outborn neonate referred from catchment areas inhabited by tribal population. But again, this is showing that heterogeneity reflect India's diversity. It preclude concluding the epidemiology of sepsis for the whole country. So it is also considered as a strength that among all over the different areas, we can see the different number of neonate with different etiology. So these are the 5 sites. Among that, site 1, site 2, site 3, site 4, site 5. But site 2 is showing maximum percentage of patient for the prolonged rupture of membrane as compared to site 1, which is only 1.6% as compared to 20.8% in site 2. Same as neonatal variables, there were preterm birth is only 9340 in the site 1, but 43.2% in the site 2. Outbounds are only 18.4 in the site 1. There are 76.9% in the site 2. And did not carried birth is only 13.5 in the site 1, but there were 40, almost 50% at the site 2. So this is showing that there is a different variable heterogeneity occurred because of this site variation. So conclusion of this study is existing literature from small single center studies highlight the need for more information on the burden of culture positive sepsis and antimicrobial resistance, and the high burden of sepsis, case fatality rate, and multi-drug resistance observed in the present study highlight the need to scale up infection prevention and control practice and establish blood culture facilities for reliable diagnosis in district level hospital in India. Can I go ahead, sir? Or
Yes, yes, go ahead.
So let us do critical appraisal of this journal club, this article by CASP checklist, which is published in the 2024. So first section is, are the result valid? The first question was, did the study address a clearly focused issues? Yes. The study's aim is well defined to evaluate the incidence of culture positive neonatal sepsis and antibiotic resistance in special newborn care unit of district hospital. The population, exposure risk context, and outcome are explicitly stated. This focus fills a documented knowledge gap at secondary care level. So the second point is for appraisal, that was the cohort recruited in an acceptable way. So we can say yes, because the cohort comprised all neonate admitted for 5 SNCU during the study period, capturing 6,612 among 6,960 eligible admissions. So almost 95% enrollment is there. So this may limit generability but does not introduce obvious bias into internal validity. This can be improved, including a larger or more representative sample of district hospital or random site selection would enhance generalizability. The third point is, was the exposure accurately measured to minimize bias? So we can here say yes, all subject meeting in the same criteria underwent the same procedure. So misclassification bias is unlikely. And overall measurement of exposure, risk factor, and microbiological data were objective and standardized and minimizing bias because of this reason. The fourth one is, was the outcome accurately measured to minimize bias? Primary outcome, culture positive sepsis, was clearly defined and measured objectively. All blood and same CSF culture were processed in certified laboratory using automated system, and isolate were confirmed and tested for antibiotic susceptibility. So we can say yes, the outcome accurately measured to minimize bias. High reliability using validated laboratory method. The fifth point is, have the authors identify all important confounding factors? So we cannot comment on this because they mainly compare the birth weight, gestational age, and site variation, but does not list potential confounders for its main analysis like maternal risk factors, low birth weight, mode of delivery, and chorioamnionitis and other things are they are not commented. The second point is, have they taken account of the confounding factor in the design and or analysis? So again, we cannot comment because of these confounding factors. The author did not use design restrictions beyond grouping inborn versus outborn or analytical adjustment for confounders in estimating incidence or AMR rates. This is the limitation. For example, higher preterm rates in some sites could confound site difference, could improve collecting detailed covariates and using multivariate model. And was the follow-up of subject complete enough? Yes, follow-up is there because they follow-up the newborn babies up to 28 days. Only 348 were excluded prior to enrollment because of the refusal, and more than 28 days. So almost 95% enrollment and explicit follow-up protocol suggests negligible attribution bias. So was the follow-up of subject long enough? Basically, they follow-up the neonate up to 28 days. They didn't follow-up after 28 days. But as per the neonatal sepsis, up to 28 day follow-up is reliable. So this point is also valid. So section B regarding the result. So what are the result of this study? The authors provide clear quantitative result for all key outcome, like 3.2% of overall incidence is culture positive sepsis. The incidence varied by site and was higher in outborn neonate than inborn. The case fatality rate for culture sepsis was 36.6%. Gram-negative bacilli account for 70% isolated with Klebsiella pneumoniae. Among them is 22.9, and E. coli 14.8, and Enterobacter 11.7. And importantly, 75 to 88% isolated of this key gram-negative sepsis species was multi-drug resistance. The author did not report formal statistical comparison or p-value, but it is descriptive, but they did supply effect estimate and confidence interval, which is sufficient for the main finding. Another point is how precise are the result. We cannot comment because precision is low, because there is a wide confidence interval. Like overall sepsis incidence is 3.2%, but 95% confidence interval is spanning is 0.6% to 14.4%. Similarly, the 36.6% case fatality rate has a confidence interval of 12.1 to 71.0%. Such broad intervals indicate considerable uncertainty in the estimate, likely due to clustering by site and the relatively small number of events per cluster. So we can improve this thing by increasing the number of sites or extending the study to enroll more cases, would narrow the confidence interval. Also, explicitly accounting for clustering, increase confidence interval with more clusters would stabilize estimates. So, can we believe this result? Yes, because most of the these results showing that gram-negative organism is the more common, which is also found in another other studies, and we can see that most of the gram-negative organism are high multi-drug resistant, which can also confirm by the other studies. So, overall, the results are credible in the direction and magnitude. As the observational study, unmeasured confounding cluster limit causal inference, but the descriptive conclusion about the incidence and resistance patterns are believable of this study. So, will the results help locally? Yes. Can the result be applied to the local population? Yes, because tertiary care hospitals are the main in the Indian healthcare sector. Over a million units are admitted to similar SNCU nationwide each year. So, the setting is relevant to Indian district level facility. The high burden of sepsis and MDR seen is likely similar to other SNCU. So, do the result of this study fit with other available evidence? Yes, as we mentioned earlier, Bernard study and NEOPS and NEOSEP1 is promoting this, also supporting this study. So, what are the implications of this study for practice? So, the result underscore urgent need in district level newborn care, as we see earlier, that authors conclude that high sepsis incidence, mortality, and MDR rates call for stronger infection prevention control measures, establishment of on-site blood culture, and antimicrobial stewardship program in the SNCU. There are sensible recommendations given to the data. In practice, this means health systems should prioritize sterile protocols, diagnostic, and judicious antibiotic use in such units. So, appraisal summary. In this large prospective cohort, the study questions were clear and the data collected prospectively with good quality control. The recruitment was robust and follow-up complete through the neonatal period. Key findings are 3.2% sepsis incidence, 70% gram-negative isolate with 75 to 88% MDR and 36.6% fatality rate. Main limitation include the non-random site selection affecting representativeness and lack of adjustment for confounded like prematurity or site variation. The result, however, coherently highlight a high MDR burden in district hospital. They are generalizable to similar Indian setting with caution, and they reinforce existing evidence about neonatal multi-drug resistant sepsis in the LMIC. The study's implication need for better infection control, diagnostic, and stewardship are justified by the data, though further international studies would strengthen the policy and guidance. So, mainly four key points need to be taken care of: prevent the infections, diagnose and treat infections correctly, use antimicrobials responsibly, and prevent the transmission of multi-drug resistance organism.
Yeah.
Yes,
Well
sir.
done, right? Thank you, Rohan.
Yes, sir.
Very recent study and very big study, actually. And very good effort by you to present this.
Thank you, sir.
So, but we admire the authors, Kajal Jain and team, right? And Dr. Jiva Shankar. So
Yes, sir.
this is the district hospital study collaborators with the funding from Bill and Melinda Gates Foundation. Uh, very novel in terms of incorporating district hospitals. We do not have much resources of sending blood culture, isn't it?
Yes, sir.
Okay. So now some questions to you, like do they have any data about outcome of the babies who were receiving first line antibiotics based on that antibiotic profile. Like some
Yes, sir.
babies were on ampicillin and gentamicin, some babies were on
Yes, sir.
cephalosporin. So
Yes, sir.
have they
They
given
have
that
data.
data?
Yes, sir.
Have they given that data?
Yes, yes, sir. They given that data in the supplementary material.
Okay, so you should say that they have a big supplementary file
Yes,
that
sir.
needs to be read properly before commenting on the original study, right?
Yes, sir. Yes, sir.
Right, right. So what about any transfer of the babies? What are the policies of those SNCUs? Whether they do any Lama, Dama or transfer of the newborns?
Uh, in these SNCU, sir, or overall?
No, overall, all the five SNCUs which were incorporated in this study,
Yes, sir.
what was the policy regarding Lama, loss to
Sir,
follow?
basically they are keeping not that much critical baby. If baby required ventilation or higher care, they referred this to the tertiary care hospital.
So if they are referring to tertiary care hospitals,
Yes, sir.
then why there is the death?
Yes, sir.
Then why are there deaths in the hospital, SNCUs?
Sir.
You get me what I'm saying? So
Yes,
if
sir.
baby
Yes,
is
sir.
getting sicker and sicker, they
Yes, sir.
usually should refer the baby to tertiary care hospital, isn't it?
Yes, sir.
So why we have a death here in the secondary? So that means they are not referring the babies who need tertiary care.
So there might be.
Have they wrote anything about it, provided any details about it?
Sir, I need to
Yes.
re-verify the
Yeah.
information.
So please be specific about this. Otherwise, if we are not aware, then we may not provide much more information. But yes, it is right that we do not have information much about Dama, Lama of the
Yes, sir.
cases lost to follow because babies are dying and they must be requiring tertiary care like intubation,
Yes, sir.
which they don't have facility. So,
Yes, sir.
detailed protocol of management with regard to this kind of thing, tertiary care management is required to be provided. We have with us Dr. Somsekar sir also available. Sir, welcome, sir.
Thank you. Sorry, I joined very late, so I have no
No
comment.
worries, sir. No worries.
But
I
it is a
think,
very significant study.
yes,
And today is the last day of Navratri, and I'm sure everyone is on the ground.
right, sir. So, we have a good strength yet still of
Yes.
participants. Uh, so, you evaluated with a different kind of checklist, isn't it? But they have
Yes.
evaluated a different checklist with strobe NI
Yes.
checklist. Are you
Yes,
aware
sir.
of this kind of checklist, strobe NI?
Yes, sir. They mentioned about it. They initially strobe data analysis, then strobe NI. They mentioned that thing,
Yeah.
but
So, can you provide more detail about strobe NI?
uh,
What is it? So, can you provide some more details about strobe?
sir, that is the mainly strengthening the reporting of observational studies. But
So, when
more
it came into
details
force?
means, sir. Hello, excuse me.
When it was first published?
कब से यूज हो रहा है?
It's a 19, 2000.
So, this is
I don't.
in
So,
published in 2007, right?
okay, sir.
So by international collaborator efforts by epidemiologists, right?
Yes, sir.
So this was further modified in terms of need of a kind of a study. So if this is a study for neonatal infection, they
And
have
it is a
provided guideline about neonatal infections, and from that strobe NI. So NI is for neonatal infection.
neural infection. Yes, sir.
Okay, so many kind of factors needs to be considered in this kind of big study. Otherwise,
Yes,
if
sir.
you don't consider this checklist in mind, you are bound to have some kind of things which you may have missed. Okay.
Yes, sir.
So to make the study comprehensive, less compliance issues, we need to follow this kind of guidelines, and they are fortunate to find this strobe NI checklist so that
Yes,
they could do this kind of study. So that was another comment that you also should have been able to evaluate based on strobe guidelines and
yes,
especially strobe NI because already they have written that they use strobenite.
Yes. Yes, sir.
What do you think about sepsis screening? Why they are not mentioning anything about sepsis screening? Because this is one of the important uh, d- factor in diagnosis of sepsis.
Sir, basically they mentioned that they decide on the basis of clinical suspicion of the sepsis. They gave the definition of how they suspect the sepsis, and they sending the immediate blood culture and starting the empirical antibiotic. But they didn't comment about any septic screen or CRP or other factors.
So that is I am interested to know from you that why they have not. So because see, the diagnosis of sepsis required some blood tests,
Yes, sir. Yes,
including
sir.
sepsis screening and blood culture.
Yes, sir.
So why they have omitted a big important factor in diagnosis, that is sepsis screening. Sepsis screening like CRP or procalcitonin, they may have a variable sensitivity and specificity, but still they are an important part of diagnosis, isn't it?
Yes, sir.
Have they
Sir,
mentioned in limitation anything on
no,
that?
sir. They didn't mention the limitation.
Okay. So see, what is your institute's policy about starting antibiotics?
Sir, mainly, sir, if we suspect clinically sepsis, then we are sending CBC and CRP, matlab main septic screen.
So you said,
Uh,
sepsis screen
yes,
first.
sir. Yes, sir. Yes, sir. If clinically proven and septic screen also favor, then we are sending blood culture and then we started antibiotic. But if clinically dilemma is there and septic screen is not in the favor, then we can wait also
Yes.
after sending blood culture, but we didn't start antibiotic on the just basis of single CRP or something else, sir.
So multiple screenings may be required, right, to
Yes, sir.
confirm or to say that this is negative.
Yes, sir.
So you can see here almost 50% of the babies were suspected to have sepsis.
Yes, sir.
So what it is about? How many percentage of the newborns get admitted in SNCU who are inborn?
Among this, sir,
Have they provided details in the supplementary file?
yes,
These
yes,
many
sir.
were the live born babies, and from them, these many newborns were admitted.
Sir, they are giving this data that 6,612 neonate enrolled, among them
That is right. That
3,972
is
are
right.
inborn.
That is right.
Yes.
For SNCU, these many were the deliveries, and from them, these many were
Yes,
admitted.
sir. That is given in the supplementary material.
Hmm?
Uh, this one, sir. Neonatal variable, site one, they included 1,742. Among them, outborn are 321. So 1,400 are around inborn in site one.
That is right.
Like,
But how
yes.
many deliveries happened in that? And from
No,
them,
sir.
how many were admitted?
Uh, no, sir. There is no that specific data is there.
Yes. So we need to have that kind of data also to understand their practices and how much risk deliveries they are managing at that institute,
Yes, sir.
right? So that is also one of the important thing. And what about compliance to KMC in those hospitals? Was less adequate, optimum hours? See, what are the factors which can help us in improving outcome by reducing sepsis?
Sir, one is the infection control prevention. Uh,
Like,
good, yes, sir.
like,
Like, sir, hand washing, hand
yeah,
hygiene.
good. Then.
There is a quality indicators about it. Then, sir, cross infection prevention. Then, sir, early enteral feeding in how much maybe they started or not. Then, sir, KMC. And, sir, minimal intervention, how well, central line or is there or anything else which can cause such sepsis introduction in the unit. So these are, sir, all quality indicators.
So nice answer. So I want to know about these details, whether they were available in that this.
No, sir. No, sir. This I on screen I just provided variables. They are not giving that in how much babies are started their trophic feed or early enteral nutrition or they gave TPN or not or like other things that KMC how much hours they gave KMC data, but there is
Okay, 3
no.
tickets. Fine. Take care. Yeah. Thanks. Bye.
Yeah. Yeah, Rohan, please continue.
Yes, sir.
So we have a background information of each center because if we are providing information like this was the culture positivity rate from that hospital. So what is the background things which are happening with regard to this kind of quality indicators is
So
very
they
essential.
provide staff ratio and all the things, but
Yes, yes,
these
that is
things
also
is
one of
not.
the important things. Nurse
Yeah,
patient
they
ratio.
provide a staff ratio and how much doctors are there and all the thing in
Yes, but
supplementary detail.
ratio have they provided not only number of the patients or doctors.
Uh,
What was the nurse patient ratio? That is also one of the important factors that you already mentioned nicely.
yes, sir.
Okay, so
No, sir.
that
Ratio is not there.
so hand washing compliance, central line clepsy rate. Do they
No,
use a central line at that center? Their centers?
no, sir. Also, no comment about it.
Okay, okay, right. Okay. So what about the defining criteria for multi-drug resistance? Do you feel that the definition is uh, as per the norms of CDC or other international body?
Mm,
How they have defined multi-drug resistance?
sir, they gave that almost, sir, all two or more than two line of antibiotics are if resistance, then they consider it as a multi-drug resistance.
You sure?
Yes, sir.
Just search it and again and tell me. Was defined as resistance to one or more agents in at least three antibody class.
Yes,
So that was the definition. Means which are the three antibody classes they defined?
sir. One is carbapenem, another is cephalosporin.
Cephalosporin. And third
Yes,
is
sir.
aminoglycoside.
Aminoglycoside.
From these three, if more or one agent is resistant,
Yes, sir.
then they define it as a multi-drug resistance. So do you feel that this is a perfect definition of MDR?
Sir, as for the CDC,
Yeah.
their criteria is same as one or more class of antibiotic resistance is MTR considered.
So more than two. Okay.
Yes, sir.
More than two or three or more antibiotic agent from each class, right? So,
Yes, sir.
so one agent from three or more classes, if resistant, right, then it is considered as multi-drug resistance. Do you understand what I'm saying?
Yes, sir.
If from the at least three, there are more than six classes of antimicrobials.
Hmm.
If from these classes, from each class, one antibiotic is resistant, right?
Yes, sir.
Then it is considered as multi-drug resistance. So they have liberally used this definition criteria. That is okay.
Yes, sir.
It's up to their choice. But universal definition is like this. Do you have any other idea about more severe resistance than multi-drug resistance?
Sir, extensive drug resistance.
Extreme,
Yes, sir.
extreme drug resistance, and
Yes,
then
sir.
beyond it, pan resistance,
So
right?
pan drug.
Pain resistance. So they are more extreme kind of definition. What do
Yes,
you
sir.
think about? They have written about some organism identification systems. Are you aware of this system?
Malditoff and sir all.
Yeah, yeah. So Marlitov. Are you aware of this Marlitov? What is it?
No, sir, not in the detail.
So that is a kind of a system which they use after the organism
Yes, sir.
growth has identified. So suppose they use Bactec bottle. When Bactec system identifies the
Hmm.
growth of organism, they will
Yes, sir.
utilize this Mardi-Toff system to identify which organism it is actually, right? So this is a kind of a protein mass
Yes, sir.
spectroscopy kind of investigation, which is done after the growth of the organism is identified. So this will help us to know which organism is there, right? What is VTech?
Yes, sir.
What is VTech?
Yes, sir. They also mentioned that thing.
What is it?
So that laboratory platform for the rapid identification of microorganism and testing of the susceptibility to antibiotics that minimum inhibitory concentration and.
So VTech is a system which help them know the antibiotic resistance. Okay.
Yes, antibiotic susceptibility. Yes, MIC and all the things.
So they have said that this kind of Marley-Top system they utilized at AIMS Delhi, isn't it?
Yes, sir. Yes, sir.
Confirmatory testing was done right at AIMS Delhi. They have written.
Yes, sir.
Are you aware of it?
Yes, sir.
So see, these five
Yes,
samples
sir.
are
Yes.
from different far places from Delhi. So how they were
Yes, sir.
sent to AIMS Delhi for further confirmation? Have they provided much more detail about this in
No,
supplementary?
sir, not more detail. They just mentioned the nodal center. They send these things and for
So
further
that kind
multi-top
of transport of these and how they mention within what time they were transferring is also very crucial. Sometimes it may take 5 days, 6 days.
Yes, sir.
How many days we are not able to get from this manuscript? They would have some system, but we are not sure what it is. Okay.
Yes, sir.
So that is one thing we should be aware of. So that's why this is a very big study and it is very difficult to do this kind of study. What do you mean by post hoc analysis?
Sir, hazard post hoc, na sir.
What is post hoc analysis?
Anyone else can answer, no? If we can't answer.
So all the participants can, it is open to you everyone. So you may answer if you are aware of this question. Okay. Jyoti is there, but all are muted. No answer or no question on the checkbox. You may unmute yourself and you may answer this question or you may ask any question. Open to you. So post hoc is what? So it is not planned before starting the study, isn't it?
Yes, sir.
So primary objectives and secondary objectives are defined well before starting the study. But when you find some interesting results, and then you want to analyze after the end of the study, when the data is collected, then it is considered to be a post hoc analysis. Okay. So that is conducted after the data has already been collected.
Yes, sir.
So this is what it is, right? So, but there are chances that there will be kind of errors with this post hoc analysis, but it is a valuable in generating a new hypothesis. So, right, some interesting findings have occurred in this study. Are there any?
Yes, sir.
Are there any interesting findings from this study, from post hoc analysis, like mortality 2 times in the people who have culture positive sepsis, isn't it?
Yes, sir.
So this might be a part of their post hoc analysis.
Yes, sir.
So this will help in future building of a new research.
Yes, sir.
Yes. So these are some of the queries or comments from my side. So Dr. Somsekar sir, do you have any question or any suggestion or any inputs?
No, though I just wanted to extend कि जो you talked about this कौन सा evaluation है तो NI वाला जो score कौन सा
Yes,
था
sir. Yes, strobe and I.
probe NI. So the point is all of these studies, not only this but other studies, depending upon what kind of methodology it is. On the equator network, you'll find various studies and how to analyze each study or how to report each study is given in detail. So, for example, consort 2025 will have different kinds of consorts depending upon what kind of trials are there. So, it is not randomized control trial, whether it is cluster randomized control trial or single patient data randomized control trial. Depending on what you are using and what you are planning to do, उसके हिसाब से वो चेंज होता रहता है. So, it is important for everyone to understand that you should be able to use all of these things to kind of, what do you say?
Start the study, right? Before you begin.
Yes, so you should use that.
Yes, so everyone are requested before you start your thesis, right? So go through this kind of checklist, that is like consort for randomized control trial. They are updated periodically. So read them carefully before you plan a study. So that is what some sir is emphasizing. Right. So I think, sir, if there are no more questions, we are
I
on
think
time.
we can close. We can close now.
Yes, yes, yes. So thank you, Somsekhar sir and Rohan. Yeah.
Yeah. Thank you, sir.
Okay. Thank you so much and good night, everyone.
Good night.
Yeah.
Bye.
Yeah. Bye, sir.